Hello and welcome to our audience, both on live now and those listening or watching the recording. Thank you so much for showing such interest and enthusiasm with this new series of shiurim. We hope to meet and exceed your expectation. The goal of the series is simple, to provide from healthcare providers with both Halacha and Hashkafa resources for medical-related ethics questions that may arise. We are actively working on both getting Rabbanim and providers to participate in the series, and also welcome your feedback by private email or direct messaging. Regarding questions or comments during the live presentation, there is a chat box. Please feel free to utilize it during the share, and the Rav will have an opportunity to address them at the conclusion of this presentation or in a future presentation. We thank our first sponsor, Lily Cares, a hospice care network with facilities across the USA. A link to their website is included in the description of the video. We would like to thank our new sponsor, MedStaff, a medical staffing company. Their website is medstaffusa.com. Rabbi Ausch is the Dayan of Avnei Eish Kahal Balkon in Williamsburg, a Dayan in Satmar, and the author of Sefer Ma'izne Halacha, and the Rav for many organizations, and has extensive experience as a posek for complex medical shilas, and fields phone calls from around the world. We are privileged and thankful for him. We are thankful to him for sharing with us today. It is my great kavod to present to you Rabbi Ausch.
Good evening, everyone. Before we begin the second series of our end-of-life discussions, I want to take a moment to acknowledge the overwhelming positive feedback from the audience from the very first session and continuing even until today. I have been deeply moved by the encouragement and heartful responses I have received. As the saying goes, you never get a second chance to make a first impression. The impression left by our first series have been both inspiring and humbling. It creates an obligation, a chiyuv, to continue the discussions with the same depth, sincerity, and dedication. I have no doubt that this conversation will extend beyond the series and beyond tonight's lecture. Your engagement and words of chizuk are a testament to our shared commitment to this important topic. May we continue the journey together with Siyata Dishmaya. Just to be clear, the guidelines presented are grounded in classical halachic sources and are broadly accepted across the Orthodox Haredi community. However, interpretations may vary slightly among different rabbinic authorities. And just not to burden the listeners, I'm not going to elaborate on all mekoides, on all sources. However, I'm available. Whoever wants to elaborate on further on the sources, I'll gladly respond. I can be reached by email, rabbiausch@gmail.com, and I'll, Be'ezer Hashem, try to respond to every and each email. In medicine, the ethical principles guiding withholding and withdrawing treatment are closely related, but they are not identical. Withholding treatment means deciding not to initiate a particular intervention, while withdrawing treatment refers to the discontinuing an ongoing intervention. From a clinical and ethical perspective, when a patient or their surrogate decides not to continue treatment, it may involve withdrawing an existing treatment rather than merely withholding a new one. To the contrary, in Halacha, in cases of terminal illness at the final stages of the illness, treatment may sometimes be withheld, while withdrawing life-sustaining therapy that is being administered continuously is prohibited. Such actions are considered equivalent to the tzitcha. Though, under certain conditions, withholding certain treatments and or medicines may be acceptable as death results from the underlying pathology and the failure to prevent it. In this instance, Halacha allows for withholding the treatment. The following conditions must be met for treatment to be withheld. Either the patient is in the final stages of the disease, or the patient is suffering uncontrollably. These criteria are critical, and their application requires careful attention to the details of each individual case. As we mentioned already last week, the decision to withhold therapy does not extend to withholding basic needs such as fluids, nutrition, and oxygenation. These essential requirements should not be withheld from a terminally ill patient, as they have been necessary throughout their life. Stopping these interventions would be inappropriate and may lead to death by starvation or dehydration. If oral feeding is not possible or is harmful, nutrition should be provided through other means, such as an NG tube or TPN or other methods, as appropriate. A feeding tube should be performed if is this best clinical situation. It is recommended to implement these measures early before the patients become too ill or malnourished. For example, in cases of demented patients, when the patient is still healthy enough, in such a cases, oral feeding continues until the need for enteral feeding arises. For a patient in the final stage of their disease, mechanical ventilation is sometimes not required if it has not already been initiated, provided that the conditions for withholding treatment are met as previously described. However, once mechanical ventilation has begun and the patient is dependent on it, it cannot and should not be discontinued. In life-threatening circumstances, the significant risks associated with analgesia are acceptable with Halacha. This is based on the assumption that in such situations, severe pain is not merely incidental. It can exacerbate the danger posed by the underlying disease. Therefore, relieving severe pain as well as alleviating anguish and depression is not only an act of compassion, but also a therapeutic necessity. As such, a certain level of risk is permissible when treating pain, just as in treating the disease itself. However, the administration of pain medication, of opioids, must be with the sole intention of relieving pain and not of hastening deaths. Narcotics should be carefully titrated to provide adequate pain relief while minimizing harm. There are deeply flawed perceptions within parts of the medical community that an elderly patient who no longer so-called contributes to society is a burden or a waste of resources to sustain. Now, I want to make a remark. I know that some might feel, what is he talking about? In my institution, in my facility, there is no way that this should be true. But what I'm telling you tonight here is what I find to be my experience with most institutions where Jewish patients are being treated. This perception becomes even more pronounced in cases where medical resources, such as life-saving treatments or medications, are limited. When faced with the choice between treating a young patient and a 90-year-old patient, the assumption is often made without hesitation that the young patient should be prioritized. However, this outlook is fundamentally at odds with Halacha. Just to quote the Minchas Chinuch, when he explains the Rambam, makes it very clear that taking a life of a gosus is considered absolute retziche, no different than taking the life of a young and healthy individual. Even more so, while it is true that the majority of those who are in a state of gesisa will not recover, Halacha teaches us that so long as a person is alive, even for a fleeting moment, their life holds the same absolute value as that of a young child who has decades ahead of him. Even, writes the Minchas Chinuch, if Yui Hanovi himself were to reveal that a given patient had only 1 second left to live, it would make no difference. The Torah does not distinguish between the murder of a newborn infant who could live for 100 years and that of someone of age in their final moments. Both are equally ritziche. This is precisely why we must do everything possible for the elderly, including those who are cognitively impaired, just as we would for younger patients. The value of life is not measured by productivity or social contribution, but by sanctity of each human being. And as a side note, let's speak openly about the argument of wasting precious resources. Do we know that society invests hundreds of millions of dollars to protect certain species, rare plants, and ecosystems, ensuring that no species is lost, no environment destroyed? The same should apply to a Yiddish or any human soul. Can we truly justify valuing a species, a plant, more than a person? A species more than a soul? The Torah perspective is clear. Every moment of human life is priceless. Every soul, young or old, healthy or ill, is of the highest value possible. And just as we go to treat with great lengths to preserve nature, we must, without hesitation, do everything in our power to uphold the dignity of a human life. Let's take a moment to discuss how we should inform a patient about a grim prognosis. In today's medical ethics, informed consent is a fundamental principle, granting patients full autonomy over their medical decisions. As a result, it has become standard practice to disclose the full scope of a patient's condition, no matter how severe. Without delving into whether this aligns with Halacha, numerous studies have shown that sharing harsh, blunt prognosis with patients can have devastating psychological effects. Patients who are told their situation is dire often experience a loss of willpower, leading them to mentally sort of give up, and tragically live much shorter lives than those who maintain hope and continue fighting. Furthermore, in today's digital age, with platforms like my chart, patients have full access to their medical records. Those who wish to explore their condition in detail can do so on their own terms. There are no secrets anymore. Given this reality, there's no reason to harshly confront patients with negativity when we can provide the same essential information in a way that encourages resilience and hope. Of course, we must follow legal requirements and provide patients with necessary medical information and with the truth. But the manner in which we communicate that information makes it a profound difference. Instead of telling a patient, you have stage 4 cancer, and based on the statistics, based on the literature, you likely have no more than 12 months to live. Can we say it's a challenge? We are dealing here with a stage 4, but science is constantly evolving. New treatments and trials are being developed every day, and we are committed doing everything possible to fight alongside you and achieve the best outcome. This approach conveys the same medical reality, but without robbing the patient of his hope. It acknowledges the difficulty while emphasizing the potential for treatment and progress. Ultimately, how we deliver the message matters. A patient's emotional state directly affects their physical well-being. And as medical professionals, caregivers, and human beings, it is our responsibility to communicate in a way that uplifts rather than discourages. There is a fundamental concept in the Torah and Halacha known as Lifnai Iver. Lifnai Iver lo sitain michshol, which means, do not place a stumbling block before the blind. These principles teach us that if someone is blind in a certain matter, whether physically, intellectually, or spiritually, we must not facilitate their wrongdoing. In Halacha, this means that if an action is prohibited, we are not permitted to assist in the execution. The concept has direct implications in medicine, particularly in end-of-life scenarios. Consider a secular, terminally ill patient who in deep suffering expresses a desire to end their life prematurely. While obviously, at least for now, Baruch Hashem, it's illegal to do it outright. But the patient requests a high dose of narcotics or pain medications, not for the purpose of pain relief, but explicitly to hasten death. This request presents a profound halachic and ethical dilemma for Jewish healthcare providers. Since actively hastening death is prohibited in Halacha, the question arises, may a Jewish doctor issue an order for such a medication, knowing that its primarily intent is to accelerate the patient's demise? May a Jewish nurse administer the morphine, fully aware that it will likely lead to the patient's death? And the same questions relate to performing a terminal extubation, which is halachically not acceptable as discussed before, since the patient needs it, and we know that doing a terminal extubation will actively kill him. The answer to this question is very clear. A Jewish healthcare provider should completely refrain from participating in such actions, whether it be ordering the medications or administrating them, because doing so is not halachically permissible. It's entirely appropriate to express one's religious convictions to your medical colleagues and nursing staff, by saying something along the lines of, due to my religious belief, I'm not comfortable being involved in this procedure. I would appreciate if someone else could step in and handle this matter. In most professional environments, the request will be respected and accommodations will be made. But let's sidestep Halacha for a moment. Let's talk about the moral consequences. There's a broader ethical and psychological concern. When a physician or nurse repeatedly prescribes medications with intent to hasten death or performs terminal extubations, something fundamental begins to shift. The sensitivity to life itself becomes dulled. The once clear distinction between sustaining life and ending it becomes blurred. Over time, a healthcare provider risks losing their deep admiration, in their deep respect for life, treating it as something that can be weighed and measured rather than something of absolute value. As Jewish healthcare professionals, we are not only guided by Halacha, but also by a moral and ethical obligation to uphold life. We must remain extra sensitive to this distinction, ensuring that our role in medicine aligns with our values and our mission to heal rather than harm. I want to conclude tonight's lecture by encouraging all of you to ask a shaila whenever you are uncertain about how to proceed. Seeking halacha guidance is not just a recommendation, it's a fundamental responsibility, ensuring that our actions align with Torah values. Let me share with you a recent episode that illustrates this point. A young man studying to become a paramedic reached out to me with a question. As part of his training, he was required to attend a cadaver lab, where students work with organs from deceased individuals. He wasn't sure whether this is halachically appropriate, so he called and asked me for guidance. I informed him that there is a well-established Pesach, not from today, not from the last generation, this goes back 200 years, prohibiting active participation in such studies involving human remains. Following this ruling, he approached his superiors, who then consulted their own rabbunim from their branch of Atzula. It was a paramedic who was to become a paramedic for Atzula, for one of the neighborhoods. Upon review, their poskim promptly issued a ruling advising their members not to actively participate, but rather to observe the training so they could still gain the necessary knowledge without violating halacha. This story highlights the important lesson. These studies have been part of medical training for quite a bit a long time. Yet one individual's halacha concern led to clarity, not only for himself, but for others as well, because he asked a shaila. He helped fellow Jews avoid violating halacha while fulfilling their medical training responsibly. So my message to all of you is clear. If something feels uncertain, if you're unsure whether it's halachically permissible, ask, seek guidance, and you will receive direction. and in the zechus of your noble work, healing and caring for people, while upholding the highest halachic standards, may you be continue to be zoiche, to be matzliach in all what you do. You should know, I'm not talking only on my behalf, but you should know that patients and their families are so thankful. They are so appreciating what you do. So when it's done medically appropriate and halachically appropriate, we have the best of both worlds. Thank you.
Okay, for our first question, is based on what the Rav is saying, is hospice ever permitted? And if yes, when?
Excellent question. The concept of hospice, when done right, when done as whatever we discussed, when it's done according to these guidelines, is hospice an absolute tool which should be utilized and can be utilized appropriately.
Next question that came in from the chat, for more related for Hatzalah members, in an MCI, in a multi-collision incident, how do Yidden Hatzalah members triage, or in an emergency room for that matter, how does one triage patients according to Halacha?
So this shaila was unfortunately discussed many times in Eretz Yisrael, where there a time when there was a lot of terrorist attacks and it was too many patients at once, and it was this exact shaila which were all medical personnel were confronted, either the local paramedics, the local EMTs, then the emergency room doctors. The ruling was in a consensus by almost all Gedolim at that time. There's no distinction between one Jew and another Jew. Whoever they reach first, they should start work on that specific patient.
Morphine that will hasten death at the same time will also alleviate pain. When is it permitted?
As we mentioned in the sheet, a patient who is uncontrollably in pain, and the only way is to give him high doses of pain medication, then we are taking the risk of hastening death, but we can't leave him suffering in pain.
And as a follow-up to that, is it a nafkamina? Is there a difference if the patient is a Yid or an Akum?
No.
We'll just wait 1 minute to see if there are any other questions. Does age ever affect the psak, the ruling, when deciding not to offer complex treatments?
Age, as we mentioned, is not a factor, it's not a deciding factor. Sometimes, with age, come certain other factors which are affecting the decision of what to do and what not to do. But the age itself is just a cosmetic. It's not a factor.
Okay. Thank you, Rabbi Ausch. Oh, we have one more question. Does one have to withhold pain medication if it will lower the blood pressure and possibly hasten death?
So it's the same question as we had before, and let's clarify it. Whenever we have a patient who's suffering uncontrollably, and the only way to alleviate his pain is with giving pain medication, with the risk of suppressing his respiratory system or lowering his blood pressure, which eventually will lead to his death, unfortunately, we must take the risk in order he shouldn't be in pain, as pain itself can hasten death.
The Rav was machalek, made a difference during the shir between starting a treatment and continuing a treatment. When is there a possibility of withdrawing a treatment that has already begun? For example, letting the bag run dry or not hanging the next bag.
Yes, absolutely. I wouldn't put presses, replenishing presses in the same category of a running ventilator. No. By presses, we sometimes, and that's the doctors who know us from prior, cases, will attest to that many times we'll tell them, just let the bag dry out and you don't need to replenish. Of course, every case needs to be directed appropriately.
The Rav said in last shir that certain times heroic measures aren't required. What affects the decision if a patient should have complex life-saving treatments such as being intubated, starting pressors, starting dialysis, etc.? Usually in an end-stage cancer patient, if they are told they only have a few weeks to live, they're not usually required to do those heroics. But we're going to put that as a question, not as a statement. But what about people with severe dementia, genetic diseases, ALS? Do they also fall into that category?
So I would differentiate between ALS and dementia. So ALS, for one, we can argue, and we have passed it before in certain cases when we discuss with the patient himself what was his wishes. Do you want to live intubated without being able to move anything of your, and if the patient says no, we would agree to that. However, demented patients without having end-stage disease of any comorbidities, just for the mere fact that the patient is demented, we will still advocate to intubate.
What is the gather of a goisis?
So, if I would be able to give you clear guidance what a goisis is, then, I think that the Gedolim from the last generation will be very happy with me, because they weren't able to define the exact nature of goisis, and especially for those patients who are intubated or having other medications pushing, like you mentioned, presses before. It's almost impossible to define when exactly disease is. So usually the way we are approaching disease with taking the blood pressure, the other vital signs, and we make a determination based on that.
Is there a difference between withdrawing treatments, which will immediately cause death, versus withdrawing a treatment which will cause death down the line? For example, let's say the patient will aspirate several hours or days later.
Great question. Now, look, we need to be emasdic. We need to be truthful to ourselves. If we're going to exhibit a patient, and we know he can push another few hours, but almost with certain that he'll require re-intubation within the next 12 to 24 hours. This is not a safe extubation. this patient wasn't ready for to be extubated now. So that this is not a sort of withholding. We are safely extubating, then withholding re-intubation. That is a classical example of withdrawing, but and we cheated the system. Meaning to say, of course, if he can safely be extubated, and the normal expectation is that he won't be, required to be re-intubated in the next 2-3 days. That's a safe extubation. But if we know that it's just we're just trying to cheat the system, so-called, yeah, that in the next few hours he'll obviously require intubation, then obviously he wasn't ready to be extubated in the first place.
What can we do as doctors when an ICU patient is deemed brain dead medically, but the family does not accept it? I think the question is they don't accept brain dead, but there's this diagnosis being made.
Right, so we touched on that topic last week, that yes, there are doctors who are trained and are from certain circles that they believe that brain death is a means of death, and we respect that. We respect, we always like to say, we can agree to disagree. So, right, they have brain death as a means of death. We don't recognize brain death as a means of death. But if the doctor is willing to have a meaningful discussion with the family, a meaningful discussion, with the rabbi, and we'll work something out. Of course, as we mentioned, those three: nutrition, hydration, ventilation, need to be continued. But we can work with the presses. We can work with other blood transfusions, dialysis. Every case is different, but along these lines, we can always manage to have a peaceful conversation, and everyone will be happy.
Is there a limit to how many bags of presses that should be given?
Presses is not being guided by bags.
So there's a follow-up to the MCI, the multi-collision incident question. That the current thinking is, let's say there's 20 people who are injured and there's the first person's there. The current guidelines by the medical guidelines and rescue guidelines are that they can't save everybody, and at the cost of deciding of who to save or not to save, they would even black tag certain people. That's the term they use. They black tag them, and then they don't bother with that person, and they move on to the next one. Is that an appropriate view in Halacha? Is that a guideline that should be followed? Or is the Rav's advice that we just go to the first person and stick with them to be in all situations?
Right, according to Halacha, you're under pressure, right? You want to help and you're limited because you have 20 people in front of you, Chas v'Shulam, all are critical. You started with one, unless he's stable, you're not allowed to leave him, to bleed out and go to the next one.
If a hospital doesn't allow patients to separate between DNR and DNI, would the psak be different in allowing DNI?
It's a case-by-case discussion. Without the hospital policy, for instance, we as Rabbunim are giving guidance every day for patients, not for patients, for families who ask shaylas, that sometimes I would tell them intubate but not resuscitate, right? We are differentiating between these two ourselves. So yes, it's not always because DNI goes together. No.
Chazal tell us not to touch a goisis. In what situations can a patient who is a goisis be moved? To relieve pain, to be cleaned if they're soiled? What about to place a blood pressure cuff, a pulse ox on them, or fix their oxygen? Can they be touched and moved for any reason?
So the consensus is not to move a goises. To touch a goises is a different story. So if you need to clean a goises because he's not kovidik, or you need to provide medication, or you need to check the blood pressure when there is no A line, then it's acceptable so long it's in the benefit for the goises.
Okay. We'll give it a few more seconds to see if there are any more questions. Thank you, everyone, for participating in tonight's share. Please follow and stay in contact about the upcoming and future shiurim.